Okay. Welcome again. My name is Lindsay Zimmerman, and I am a registered nurse with TDH. Next slide. Today, we're going to have a presentation by Dr. Clark Allen regarding managing acute and chronic hepatitis C virus. We will also have case presentations and then any questions and answer sessions that anyone may have. If you can take just a moment to put your name in the chat and introduce yourself and just put whether or not this is your first echo session. And while we take a moment to do that, as always, continuing education credits are available for these sessions, but you do have to register through the SEAETC. The QR code is available or the link. We'll take just a moment for you to have time to do that. And also, I just want to say, Kimber put her information in the chat. If you do have any technology issues, please reach out to her. All right, we'll go forward. And if no one has any issues, we'll go ahead and move to the next slide. And I will turn it over to Dr. Allen.
All right, thanks for the introduction, Lindsay. So today, I don't see if anybody's had if this is their first echo session, but today we will kind of be going through distinguishing acute versus chronic. So for anybody who's new to the program, this would be a good way to just start from a baseline knowledge of kind of understanding what is an acute infection versus what is a chronic infection. We can go to the next slide. No conflicts of interest to disclose for the purposes of this conversation. Next slide. Do you have some objectives that we want to make sure we cover? We want to make sure we're defining what acute hepatitis C infection is versus what chronic is. I want to make sure we're interpreting labs or how to interpret labs during the acute phase versus what they would look like in the chronic phase, describing discrete versus non-discrete infection or exposure, and also knowing what symptoms to look out for in acute settings. Next slide. Have a couple basic abbreviations. I always want to make sure we're using abbreviations appropriately and make sure we're defining abbreviations. So here's a list of abbreviations that may not be disclosed during the session today. So I want to make sure we have those listed. Next slide. So then we can talk about initially what to look for or how to diagnose or how to identify patients with a acute hepatitis C infection and how we can distinguish that from a chronic one. So let's go ahead and go to the next slide. Most of what I will be referring to today is in the guidelines, so I want to make sure that we have a resource of what we're using as far as our presentation. So everything that can be that is presented today will be associated or in the guidelines. So first things first, when we're looking at determining if a patient is to be diagnosed with acute, we want to make sure we're looking at hepatitis C antibody and a viral load when we're trying to determine that. And we'll kind of look at timing of those things as the presentation goes on. We also want to look at an elevated aminotransferase or ALT or AST. Those are labs that we'll be looking at as well as far as a determining factor to determine if it's an acute phase or maybe it's more of a chronic phase. Next slide. So what is a potential exposure or risk factor that patients can be exposed to that could potentially subject them to an exposure? So that includes any type of parenteral exposure of IV drug use or any other type of needle stick. So that can include a maybe social aspect of using needles, or it could be accidental needle sticks in the healthcare setting. So not just in the social setting, it could be in the healthcare setting that patients or employees or employers could be exposed to hepatitis C in that manner. If those were to happen, we want to make sure we get proper testing accordingly afterwards. Also, through unprotected sex, it could be heterosexual or homosexual sexual encounters that could be there could be an exposure to hepatitis C in those scenarios. Non-steroidal tattoos, mainly we're going to see that in the prison systems where they're not using proper sterile techniques when using the same type of ink to use it on several different people. So there could be a swap of hepatitis C exposure through that of using sharing needles through sterile tattoo non-sterile tattoos. There's also a lower risk or still not as common thing of sharing razors or toothbrushes. So hygiene products, that's also something we want to counsel patients on to not share hygiene products with anybody just because there's potential of any type of blood swap. Through that, it could be an exposure to hepatitis C if you don't know their status. So those are kind of main risk factors of how a patient can be exposed. In the past, there could have been an exposure through blood transfusions. Since 1992, we have great screening tools to make sure we prevent any type of patient to be exposed from a blood product, receiving blood products in the hospital setting because we have screening tools in place since that time. So that's something that used to be in the past, not something we have to worry about now. Next slide. So now I mentioned in the objectives, discrete versus non-discrete. So they're kind of self-explanatory, but I want to kind of lay out what I mean by that. A discrete acute infection would be something of the risk factors we just disclosed, where you know in the recent past that if a patient talks about one of those risk factors, we would call that a discrete exposure. That means that they've had one of those encounters or some type of risk factor that is associated with transmission of hepatitis C. So that would be indication that we know that there's a potential source for this, and that is a reason to test and screen a patient for hepatitis C at that point. Now, as far as when we get to people who have non-discrete acute infections, that would be a person that's harder to define or distinguish because they don't have a current risk factor in place. They didn't mention anything in your interview, so it would be harder to diagnose acute hepatitis C in a non-discrete patient just because there's no kind of risk factor that has been presented during the patient interview. There is a reason to, and this is the reason where you want to check for liver labs, so that you would need to check a CMP to check for the ALT. And if you see an increase or an elevation in the ALT lab that has no other cause or reason, then that would be a potential reason to check for hepatitis C antibody to know if there's been exposure in the recent past for that. So definitely want to make sure we determine those things. And there is guidance, as we discussed in the past, that anybody who's over the age of 18, there's a universal screening guidance that we should screen everybody over the age of 18, regardless of risk factors, just because there are patients that maybe weren't not even aware that they were exposed to hepatitis C in their past, either acutely or chronically in the past. Next slide. Now, we can talk about timing of different labs in the acute setting. So this is we'll kind of hang out here for a minute because I want to make sure we go through these things slowly. Now, during the acute phase, there are potentials where you can get high variability of responses on the hepatitis C labs. So, we're going to have a chart on the next slide as well to kind of explain this, not just in word form, but more in picture form to make it make more sense. Hepatitis C antibody can be negative even up to 6 months or 6 weeks, excuse me, after the exposure. So there's a potential chance of even if you patient has a risk factor in the last 48 hours, there's a potential that they will still screen negative, and that will be a reason to just continue to check a hepatitis C antibody going forward for the next couple months as they follow up, because we want to make sure there's a potential it could present later. Another a different hepatitis C lab, the viral load or the quantification, the PCR, lots of different words can mean the viral load of the hepatitis C. So we want to check that when we know a patient has been exposed. One of those discrete risk factors. So it can be negative, it can be elevated, it can decrease, and then it can elevate again. So there's lots of variability and fluctuation in the viral load in the acute phase. So just because if a patient has a risk factor and just saying that their viral load is negative, it doesn't mean that it's going to be negative forever. So we want to continue to follow up that patient and check a viral load in the subsequent months going forward, just to make sure that continues to remain negative, or if maybe it comes up positive, that's a reason to think that maybe it was acute infection and there's just some high fluctuation or variability during that acute phase. And then also the alanine transaminase, that is the AOT. That's another lab that we can do to monitor as far as seeing if there's any elevation in that, which would mean there's inflammation in the liver that would indicate there's a potential hepatitis C infection. There could be other reasons as to why their AOT is elevated, but if you see an elevation that has no other cause or reason in that patient, there's a potential chance that there is an acute infection. There are potential patients in rare cases where there can be misleading labs in this scenario where they can be false positives, and that would usually become in immunosuppressed patients. So we want to be aware of other medications a patient might be on. Sometimes we can get variability in what we might expect if the patient has a discrete risk factor but is immunocompromised. There can be variability in those things. We also want to talk about the seronegative window. So what that means is that's a potential chance for the hepatitis C viral load to be positive and then the hepatitis C antibody to be negative. So that would show that there's an acute infection because the antibody test has not even had time to present itself, but the viral load is present. So that would mean that, oh, we're in the acute phase definitely because the antibody test has not even had time to present itself in as far as the lab. So that's what I mean by a seronegative window, where you have a viral load but not an antibody test yet. And that would be an indication. We would call that acute infection. And we will get down to later in the presentation about what to do when we find that. Whether we treat now, do we wait? We'll cover that in just a couple of slides. So I don't want to spoil it just yet. So let's go to the next slide now and kind of look at a visualization of what we've been talking about. Now, looking at this one, there's lots of different things. You can review this in the guidelines as well. So this is just something I pulled out of the guidelines to kind of make it as far as a visual. Lots of different scenarios on the left side, and which is what we've covered just now. So in the top left, when there's antibody negative and a viral load negative, that would be no infection. But if there's a discrete risk factor, that would be a reason to continue to check those labs going forward throughout the next 6 months. And when I say 6 months, that's kind of what they've drawn a line in the sand. If they don't have any positive antibody or positive viral load in the next 6 months after that exposure, uh, there's potential that nothing happened and there's no reason to follow up further. So there would be no infection considered in that standpoint. And so no need to indicate it for treatment because nothing ever came back positive. And there's also potential chance of antibody positive, but the viral load negative. There's a potential chance that the viral load increased, but then it came back down, and we would call that a spontaneous clearance. Sometimes about 15-20% of the time, there is a chance that the viral load can be fully taken care of by the immune system and it be not detected. That would be also a reason to not treat that person. They do not need any antiviral medication for hepatitis C because they don't actually have the virus. And then the next one is where the antibody is negative, but the viral load is positive. And that's when the scenario of the seronegative window would be considered, where they do have the virus positive present, but the antibody is not presented yet. That would be a time they would be indicated for treatment at that point. And of course, the most common one is if they had a discrete infection recent or a discrete exposure recently, but they have an antibody positive and a viral load positive. It's more likely they had a previous infection already, and then maybe they just had a new risk factor exposure, but they already had the virus. So if both of those are present and it's in the narrow time window of about 48 hours since they were exposed to this recent risk factor, they might already have had a hepatitis C infection before that. They just had a new risk factor or a new exposure to it. It would not change the outcome. We would still want to treat that patient and get them into care to consider treatment going forward. Next slide. So, what do we do about patients who are in that time period of the 6 months where they don't have a viral load yet, they don't have an antibody, but they had a risk factor or a potential exposure? What do we do about that? Is there anything we can do? So, for other viruses, there are medications that we can use for pre-exposure prophylaxis or post-exposure prophylaxis. For hepatitis C, due to there's not any data, and there's for cost-effective reasons, there's not a reason for pre or post-exposure prophylaxis at this time for hepatitis C, just because the medications at the market, to be realistic, they're very expensive. It would be hard to kind of get anybody on board to want to continue just to take a hepatitis C medication, either pre-exposure or post-exposure, without an actual viral load or it being deemed an active infection, either acute or chronic. It would be very hard to kind of explain to somebody to want to get on board with that. So right now, within the current guidance, no reason to treat for pre-exposure or post-exposure prophylaxis for hepatitis C. But yeah, it's a great question that it comes up from time to time about if a partner needs to treat. Usually, if their partner does have hepatitis C, we treat abstinence in those patients because we want to make sure we prevent any type of contact that could be a potential exposure while one of the partners is on medication and the other spouse does not, or the partner does not. We want to keep it that way, but there's no indication for medication at this point. Next slide. And so now, what do we do once we've got a patient who has hepatitis C? The main point to point out is we don't want to delay once we know we actually have an acute infection present. So same rules apply for a chronic infection. Once we know that the viral load is present and it has remained present, we don't want to kind of sit around and wait to see if it's going to spontaneously clear. If we see a viral load present, we want to go ahead and treat that person because there is a risk if we play the waiting game and try to just see if it's going to spontaneously clear. There's a potential that patient may lose interest and may fall out of care, and then we won't know the true answer whether it did it clear or not, or we should have just treated them on the front end, and that way we would know for sure that they were going to be cured. So that's kind of our stance with the guidelines is to not wait. If we have a viral load, we should go ahead and just start the process of starting that patient on treatment. Now, for individuals who do have an acute infection, once we start them on medicine, we do want to make sure we're counseling on their behaviors. So that includes the risk factors that we mentioned in the beginning, like what are they participating in that cause them to be exposed. We want to make sure we're counseling on minimizing and avoiding those encounters or risk factors in the future because we don't want to treat them and then lead to a reinfection and have to start the process over. We want to make sure we're promoting healthy habit and lifestyle changes to promote for the future. That way, we one, get rid of the hepatitis C, and two, promote healthy lifestyle changes and habits going forward to make sure we prevent reinfections. Next slide. Now, as far as once a patient has acute hepatitis C, there can be a very wide range of symptoms. Most of these are very common to most people on the call or on the session, but most patients will be asymptomatic. It's very common for patients to be exposed to hepatitis C but never even know it, which is all the more reason that anybody over the age of 18, we should be screening at least once in their lifetime, regardless if they have any risk factors. So that's all the more reason to do that. As far as other symptoms that may actually occur, there could be abdominal pain, very indirect. Could be fever, fatigue, very just normal viral cold-like symptoms. Could be anything: nausea, vomiting, itching. Now, the jaundice and dark urine and elevated liver enzymes, those are going to be more specific. So those are things that you will want to be checking for as well. So as far as thinking about a patient for the symptoms, we just want to make sure we're monitoring, like, do they have risk factors and do they have symptoms that would kind of lead us to believe, and we want to do further lab work follow-up to kind of look at their liver labs, look at their hepatitis C antibody, look at their viral load if we have a patient experiencing these specific symptoms. Next slide. Now, what I did mention earlier is that there are patients that can spontaneously clear it. And so it kind of goes back to when are we talking to this patient versus when they had an exposure. So if you know they have an exposure recently and around the 48-hour mark, that's when we want to check the labs. But there is a chance if they've had a previous infection or previously exposed in the past, there is a potential chance, 20-50%. The numbers are vary widely in the literature. It can be, I usually hear 15 to 25, but it can be up to 50% of patients can spontaneously clear it. That just means that their hepatitis C viral load would be negative even after exposure. Now, that means that their hepatitis C antibody will always be positive. And that's something that I counsel patients at the end of treatment, is that regardless of what happens, whether they go through treatment or not, whether they need it or not, their hepatitis C antibody will always be positive going forward because they've been exposed to the virus. They will always have that antibody. So that's something to counsel on at the beginning of treatment and after the treatment, letting them know what we're looking for to be negative, which is the viral load, but the hepatitis C antibody will always be positive. Now, usually in the clearance can occur in the first 6 months. About 66% of patients will clear it in the first 6 months, and so it's a little more rare for patients to spontaneously clear an infection after the first 6 months of an exposure. So, if they're, of course, when they're spontaneously clear, they're not indicated for treatment because they won't have a viral load to treat on. So that would be an indication of you don't have to worry about that. But of course, counsel on risk factors for avoiding it. And then we want to make sure we're screening patients periodically in the future if they have risk factors or risk behaviors that continue. One thing before I go to the next slide, I did skip something. I want to make sure if we see a patient that has been exposed to hepatitis C, we want to make sure we're screening for other viral infections. So that includes hepatitis B, HIV, and potentially any sexually transmitted infections as well. That's something that should be on your mind. If you see that they're maybe have a hepatitis C infection acutely, that would be a reason to screen for other type of infections as well. So I want to keep that in your mind as something to kind of follow up as far as your following up as a primary care doctor. Next slide. So now we've kind of already hinted at what we're going to do with treating of hepatitis C in the acute phase versus chronic phase. And we'll go to the next slide. So the guidance doesn't change. So if, like we said, if a patient has an acute infection and we know it's been recent and we have a positive viral load, we want to go ahead and just start the patient on treatment as soon as we can get them approved by insurance or through patient assistance, whichever their path for their scenario is. We want to get them on medicine because we know that there's a risk of loss to follow up in these patients if we try to play the waiting game for the acute infection to either clear, or if it becomes chronic and just wait for that. We'd rather just go ahead and treat them now, just because it's in our favor to go ahead and keep them in care while we have them, because the medication regimens are short. So we've got the 3 different first-line agents. We'll probably just stick with the simplified guidance regimens, which is Cacaprofir, Propensiosphere, trade name Mavorite. That's indicated for 8 weeks for anybody who's treatment naive, recently exposed. And then Sofosbuvir, Hepatosvir, trade name Epclusa, is for 12 weeks for a treatment naive, recently exposed patient. And then it would be outside of simplified guidance to do Lenticapavir, Sofosbuvir, trade name Harvoni for 8 or 12 weeks. There are stipulations to how you get 8 weeks, but you do need to be genotype 1A. So that would kind of go outside of the simplified guidance. So we'll stick with just sticking with the 2 main agents that we use to treat chronic hepatitis C as well. So the guidance doesn't change as far as treatment of hepatitis C in the acute phase. It's just more about knowing what to look for and kind of what to expect as far as the lab work. Lab work can be fluctuating in some variability in that acute phase. So that's kind of the main thing to hammer home about this presentation, is just knowing that don't be surprised if you potentially get a hepatitis C antibody that's negative, but maybe get the viral load positive. That means, yeah, you are definitely in the acute phase, but still does not change your overall treatment goals of going ahead and starting the treatment process for that patient. Even if you don't have a genotype, we can still use simplified guidance to start the process on that patient. Next slide. I believe that concludes. So I want to open it up for questions. I want to make sure there's lots of lab work that I talked about with this one, several different timing things. So yeah, feel free to drop a question in the chat or come off mute if you've got any questions about timing.
Dr. Allen, there is a question in the chat.
Okay. Yeah, it says I frequently see patients with recent less than 6 weeks of high-risk IV drug use. Do you recommend running a phlebotomy-based hepatitis C antibody test at all, or just run an HCV viral load? I would just lean on the guidance based on the graphic that we showed. We can check to see. We can always check a hepatitis C antibody first. It's a quick test, not very expensive, but checking both of them can kind of tell us one of 2 things: is it an acute phase, less than or in the short time, or if they're both positive, as we said, hepatitis C antibody plus the viral is positive, potentially they have been infected for a while. So I don't see any drawback to checking both. Just to kind of, it could tell us if they're in the acute phase or not. I can let Dr. Chastain, Dr. Alfredo Cruz chime in with their area of expertise as well, if they've got other opinions.
It's a great question. And I think that from a cost and utilization standpoint, it probably makes the most sense to use the antibody with reflex testing to RNA testing. That's with the recognition that you may miss some subclinical acute hepatitis C infections in that patient population. But there's also downsides of false positive tests with using RNA PCR tests. And you'd say, well, why would that occur? Because RNA PCR tests should be very specific because it's looking for genetic material that has more to do with the fact that genetic primers may pick up genes that are actually not relevant to hepatitis C, might actually amplify something else. It might have to do with the platform as far as how that the one caveat I would say here is if you have a patient who has nausea, vomiting, abdominal pain, jaundice, scleroicterus, things, I would not rely on an antibody only, and I would not rely on an antibiotic reflex because, as Dr. Allen mentioned, acute symptoms of viral hepatitis may indicate hepatitis C, and there are patients who will have a hepatitis C RNA that's positive with a negative antibody. And those are patients that you may want to intervene on, both from symptomatic control, diagnostic evaluation, and even possibly early hepatitis C treatments. And so in my practice, even in patients who have significant risk, I rely on antibody with reflex to RNA testing.
Right, yeah,
I
because you
choose
wanted the
to order RNA testing directly in patients who have very overt specific exposures that they're concerned about or symptoms.
Great question, Caitlin. Thank you. Does anyone else have a question for Dr. Allen or Dr. Chastain? I actually have one. So when referencing spontaneous clearance, are there any conditions or even age that play a factor in if someone is able to spontaneously clear?
To my knowledge of what I've read, I'm not sure if age plays a role. I do know can play a role in if you're exposed later in life that you have a higher chance of developing cirrhosis. But just thinking about being exposed later in life, does that have a higher or lower chance of spontaneously clearing? I am not sure. I'll see if Dr. Chastain wants to weigh in.
I think I can tell you that from a pediatric standpoint, we know that we actually give them the first 3 years because we know there can be some spontaneous clearance that usually things to be associated with their immune system that it's developing and sometimes is able to actually defeat the virus. So from a pediatric standpoint, I can tell you we usually kind of have that cutoff as for age. I think for adults, I'm going to have Dr. Chastain kind of give his input regarding that.
Yeah, thank you so much. I think that it's a great question, and there is some data to suggest that age does have an impact on the likelihood of spontaneous clearance. But I'll say data is complicated. What I mean by that is that when you're studying populations who are infected with hepatitis C, you're focusing on the subpopulation group. You're not looking at the population as a whole. And often there are different demographics that might be represented in one clinic or in one state or in one region or wherever that data pool might come from. With those limitations, we do think that among adult patients that the younger you are, the more likely you are to spontaneously clear. And that really has to do with general health of the immune system and the degree of reaction and activity that the immune system may generate. And so in that context, younger patients are more likely to develop a robust immune response to hepatitis C and thus are much more likely to spontaneously clear it than an older patient. Now, is there a dramatic difference between someone who's 40 and 45? Probably not. Is there a difference between someone who's 30 and 50? Maybe some. Is there a difference to someone who's 18 versus 80? Probably a lot. But a lot of this has to do with what we recognize as waning as far as immune function in older adults. So in addition to that, the data is complicated because no group of people are just younger or older within a cohort. There's also a lot of other demographic factors that might be represented, including gender, including ethnicity, and the genetics that might underpin that, as well as other factors. So there is, again, complicated but circumstantial data that suggests that younger patients are more likely to clear. Patients who are immune competent are more likely to clear than immune compromised. Women may be more likely to clear, spontaneously clear than men. And specific ethnicities might be more likely to clear than others. This really doesn't have any clinical implication to how I practice, though. I think that spontaneous clearance is possible in all my patients. I treat all acute infections when I can identify them and intervene in a timely form and fashion. And I don't generally delay treatment in patients who have confirmed infection unless there's clear evidence that they've either already spontaneously cleared or are in the midst of spontaneously clearing. Would be the only reasons I would withhold. So it's academically a really interesting question. It's scientifically a really interesting question that has very little implications for how I approach individual patient care.